Assalamu alaikum. It's a very short video where I will discuss about how to approach hypoxemia. If a patient comes with hypoxemia, look at the PaO2. This is found via ABG arterial blood gas. Okay, before jumping into the conclusion, first I would like to read the stem. A 44-year-old woman is evaluated for why hypoxemia. One day after she underwent open cholecystectomy for complicated acute cholecystitis, the patient has been receiving continuous normal saline, hydromorphone, antibiotics. Medical history is significant for heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction. Temperature is normal, blood pressure is again normal, pulse 92, respiration 12 per minute. Oxygen saturation is 80% on room air and BMI is 40 kg per meter square. AVG analysis results in arterial pH 7.24, arterial oxygen 59%. Arterial oxygen is actually low. PaCO2, partial pressure of carbon dioxide, is higher. Normal is in between 40 millimeter of mercury is the standard, and bicarbonate is normal. It is within 22 to 28 millimeter milliequivalent of water. The AA gradient, alveolar arterial gradient, normal is 4 to 15, it is 12. So normal AA gradient. Which of the following is the most significant contributor of hypoxemia? Okay, if somebody comes with hypoxemia, PaO2 is less or equal 60 millimeter of mercury, and his alveolar arterial gradient is normal. His alveolar arterial gradient is normal. Okay, now look at the flow chart. If a patient comes with hypoxemia, PaO2, arterial oxygen is less or equal 60 millimeter mercury, then we will do the alveolar arterial gradient. If it is normal, is if it is not elevated AA gradient, no, then we will do elevated PCO2. If PCO2 is high, then think about alveolar hypoventilation, and it has two causes. Peripheral is neuromuscular disease, and central due to opioid using or obesity hypoventilation syndrome If mm, elevated PaCO2 is if PaCO2 is not elevated, no, then low inspired oxygen, then low inspired oxygen. If low atmosphere, it is low uh, atmospheric pressure, then it is high due to high altitude. If it is low fraction of inspired oxygen, it may be due to asphyxiation. So if PaCO2 is not elevated, then two differential. If atmospheric pressure is low, then it is due to high altitude. If atmospheric, if fraction of inspired oxygen is low, it may be due to asphyxiation. Now, if elevated AA gradient, if alveolar arterial gradient is elevated, yes, and it corrects with 100% oxygen. If it does not correct with 100% oxygen, no, it may be due to shunt. It may be due to right to left shunt. It may be due to intrapulmonary shunt effect. It may be intracardiac, true amniotic. Corrects with 100% oxygen, corrects with 100% oxygen. Yes, Diffusion limitation, DIE, diffusion limitation is ILD and emphysema, and VQ mismatch. And VQ mismatch, it may be due to focal pneumonia and segmental pulmonary embolism. Segmental pulmonary embolism. Okay, before jumping into the conclusion of this discussion, I would like to talk about these ABG gas interpretation of acid-base disorder. If pH is less than 7.35 low, it is acidemia. If bicarb is low, if bicarb is low, less than 24, it is primary metabolic acidosis. If compensatory response, secondary respiratory alkalosis, primary metabolic acidosis, its compensatory response is secondary respiratory alkalosis. That means decrease PaCO2. If acidemia, if PaCO2 is higher, it is primary respiratory acidosis. Delayed uh, compensatory is secondary metabolic alkalosis. So for respiratory acidosis, secondary metabolic alkalosis. Alkalemia, alkalemia, if a PCO2 is low, that is PCO2 is low, primary respiratory alkalosis, delayed secondary metabolic acidosis. And alkalemia, if bicarbonate is higher, more than 24 milliequivalent, it is primary metabolic alkalosis, and compensatory response is secondary respiratory acidosis. It's a simple thing, but we are confused in the exam because in the exam our mind does not work in a normal way. Okay, that's all about approach to hypoxemia. It's a very small video. Hope you enjoyed.